introduce Maria Drakopoulou, who is a consultant cardiologist, colleague and friend, and the co-lead of the ACST service at the Hippokration Hospital in Athens and the Kapodistriakou University of Athens too. And Maria would present, as you can see, pregnancy and Marfan syndrome. Good to have you with us, Maria. Thank you.
Thank you so much, Prof. I would like to thank the organizing committee for the kind invitation. And for the next few minutes, we will talk about Marfan syndrome and pregnancy. And as you can see, Marfan syndrome belongs to a group of heterogeneous diseases that have to do with thoracic aortic diseases. And it's the prototype of this group. It's the model of this disease. And the predominant feature for cardiovascular manifestations is the dilation of the aorta. However, there are other systemic manifestations, as you may see. And it's a connective tissue disorder that affects the mutation to the gene encoding fibrillin 1 that is located at the chromosome 15. So we see that about 80% of patients have cardiovascular complications, not only located at the aorta, but also other cardiovascular complications, as we can see in this slide, concerning the pulmonary artery that is often dilated, mitral valve prolapse with concomitant regurgitation, LV dysfunction that is not dependent on the valvulopathy, arrhythmias, as well as atherosclerosis. So we see that the Marfan patients have the definition since 2010 that the GAIN criteria were updated, and the GAIN criteria include genetic as well as clinical conditions. And there is a great discussion during the last years concerning the other cardiovascular manifestations and whether these manifestations should be included in the definition of Marfan syndrome. And we see from the recent guidelines of the adult congenital heart disease in 2012 that Marfan syndrome is actually of moderate complexity. And of course, every patient with Marfan syndrome should be followed in a specialized center with experience. And as you can imagine, pregnant patients or patients that are considering to go for a pregnancy should be followed by a specialized team that includes a lot of expert doctors, and we need an individualized plan for delivery. So there is a wide spectrum of severity in Marfan patients, and as we can see in this slide, this is a patient with Marfan syndrome with a normal aortic root size, no regurgitation of the aortic valve. There is a prolapse of the mitral valve, but not significant regurgitation, and a normal aortic arch concerning the size. At the other edge, there is this extreme spectrum with a significant dilation of the aortic root. This aortic root is about 50 millimeter, concomitant severe mitral regurgitation with mitral valve prolapse of the valve and LV dysfunction, as we can see from the four-chamber view. So there is a wide spectrum, and we need to know the severity of the cardiovascular complications. Concerning pregnancy, what are the adaptations that happen during pregnancy, and how can this affect the patient with Marfan syndrome? We know that during pregnancy and from the beginning of the pregnancy, during the first weeks, the total peripheral resistance decreases. However, heart rate and stroke volume significantly increases, leading to the very high cardiac output throughout the pregnancy. And this hemodynamic change provokes stress in the aorta that may affect not only the size, but also the elasticity. And we see even in healthy women that undergo pregnancy, there is an increased aortic elasticity and a transient aortic growth during the pregnancy. So one can imagine how a Marfan patient can be affected by these hemodynamic changes, and taking into consideration that the aortic size may vary when there is concomitant hypertension during the pregnancy, as well as the compression of the uterus on the aorta, imposing the upper aorta with greater stress. All these factors seem to affect a Marfan patient. Despite the hemodynamic changes, there are also some hormonal changes. As you can see in this slide, the medial layer of the aorta is influenced by the hormonal changes, the increased levels of estrogen and progesterone because as we have seen in this nice publication, there is a high level of receptors concerning these hormones in the systemic arteries as well as in the aorta. So there is a loss of the elastic fiber organization in the medial layer of the aorta, possibly playing a role in Marfan patients that have a fragile aorta. Going to the short and long-term outcomes after pregnancy, we know that for every congenital patient that thinks of going for a pregnancy, there are the cardiac, the obstetric, and the prenatal risks. And of course, among patients that experience dissection during pregnancy, in this small group of patients, we see that the predominant patients are patients with Marfan syndrome. So there are two concerns concerning Marfan syndrome patients. The first is the possibility of dissection of the aorta during pregnancy or at the postpartum period. And the second concern is aortic growth during pregnancy. And there are several studies, mostly small studies, retrospective studies that have seen the incidence of dissection during pregnancy or postpartum period. And we can see that there is a wide variability, possibly due to the different inclusion criteria of Marfan patients, possibly due to the difference in the medication. Some patients were on beta blockers, whereas others not. And of course, some patients had prophylactic aortic root therapy. So there are three prospective studies that we may discuss later on. This is the biggest registry, the GENTAC data that showed a high prevalence of pregnancy-related cardiovascular complications. As you can see here, 94 patients and 227 pregnancies overall, 10.6 cardiovascular complications with 7.4 aortic dissections. And as you can see here, most of the aortic complications, 5 patients had a prior aortic root repair. So 4 patients among this group had aortic complications. 1 patient from the group with a small aorta and 3 patients from the group with an aorta more than 40 millimeters had cardiovascular complications. And this study showed that pre-pregnancy aortic root replacement does not fully normalize the risk of aortic dissection. So overall, the conclusions of the study were that the low risk is when the diagnosis of Marfan patients is known, when the root is less than 40, when there is a good preconceptual counseling, and when there is regular imaging with good and tight blood pressure control. On the other hand, when the patients had aortic root dilation at baseline over 45 or rapid growth during pregnancy and previous dissection, there was a higher risk. This is a very nice study from Brompton Hospital and Professor Gajuli showing the experience there, published in 2014 in 21 patients. And I would like to focus mostly on the description of LV dysfunction in 2 patients that developed during pregnancy. So we should check also for other cardiovascular complications, not only the dilation of the aorta. Concerning the aortic root growth, I will focus on the small number of prospective studies. This is the first prospective study published in 1995, showing no significant difference in aortic root growth. And for a mean follow-up of 6 years, no significant difference in events among patients that had a pregnancy compared to those that did not. So this is the second paper that was published in 2005, showing that overall there was no difference in the aortic growth, but at the subgroup analysis, patients with a large or more than 40 baseline aorta showed a slightly accelerated growth during pregnancy. And this, of course, shows the high risk of patients with increased aorta diameter during baseline assessment. And this is the publication in JACC from 2012 showing that indeed during pregnancy there is a growth of the aorta. However, at postpartum period, the growth and the diameter diminishes, not of course coming to the baseline. This study showed that during the almost 6-year follow-up, patients that underwent pregnancy had a higher risk of adverse outcome versus the patients that did not undergo pregnancy. And of course, initial aortic size and the rate of increase were the predictors of long-term adverse outcomes. And this is the sub-analysis of the ROPAC registry that included 189 patients with thoracic aortic disease. Almost half of them were Marfan patients, and overall, 4 patients had dissection during pregnancy. Of course, as you can see, the majority of patients were Marfan patients, and most of them had a high aortic diameter at baseline. Several guidelines and consensus papers refer to this topic, Marfan patients and pregnancy, and this is the most recent genetic counseling publication concerning the counseling that we should offer the patients that come to the pregnancy clinic. And it is very important to confirm the diagnosis, guide management, and of course, estimate the prognosis of this patient and talk with the patient to see where we are. As we know, the gene encoding Marfan syndrome is at the chromosome 15, and the mutation is autosomal, so there is a high possibility of recurrence at the offspring. So these are all topics that we should discuss. And as you can see in this slide, first of all, and the ideal is that we see the Marfan patient before pregnancy for assessment. And we need to know with imaging modalities such as the echo and MRI, the whole aorta and other cardiovascular manifestation of the disease. Check the drug treatment, discontinue ACE inhibitors and ARBs and switch to beta blocker. And of course, have discussion with the patient and estimate the maternal, the offspring risk, and offer genetic counseling. And as we can see, we need to estimate the risk of the mother and the fetus based on the classification of the modified WHO classification. And as we said, we need to have the imaging of the aorta pre-assessment. So based on the modified classification, we consider patients with Marfan syndrome and a good aortic root with no dilation at the class 2 to 3, those with a 40 to 45 aorta at the class 3, and those with a higher size of the aorta at the class 4 with, as you may see, increased possibility of maternal event rate. So the risk estimation should be done again during pregnancy, as we need to know how is the aortic root going. And also the recent guidelines of the adult congenital heart disease position Marfan syndrome to 3 class or 4, depending on the size. And the pregnancy should be avoided in case of a previous aortic dissection, as the patients in this class have increased risk. So what about the elective intervention that is often discussed of patients that plan to have a pregnancy? As you may see, over 50, there is an indication class 1 to go for an aortic root size repair, whereas if there is a plan for pregnancy, then we should go for a lower diameter. We should go for a surgery earlier than reaching the 50 cutoff value for other patients. So it is a class 2A to go for an elective intervention before pregnancy in patients with 45 diameter or more. Concerning the offspring, we know that the recurrence rate is quite high, and as you can see here, there are 50% of chances for the offspring to have Marfan. So we need to talk with the parents and, of course, offer a prenatal genetic diagnosis or even pre-implantation genetic diagnosis. It is very important to underscore that the mutation does not always predict the severity of the clinical disease spectrum. Concerning prenatal genetic diagnosis, after discussion with the patient, this is a good invasive, though, test to see if the patient has the gene of Marfan. And of course, there are other techniques as pre-implantation genetic diagnosis that we can be sure that the patient is not a carrier of the gene, the offspring. There are several unanswered questions concerning the prophylactic aortic root surgery, the effect of hormones when we go for an IVF procedure, as well as ethical issues concerning these topics. Regarding the obstetric and fetal outcome, there are no significant reports concerning the outcome at this stage. So it seems that there is no difference between patients with Marfan and no Marfan syndrome. Let's go to pregnancy management. As you can see, all these patients need to be followed up during pregnancy by specialized centers and teams that may estimate the progression of the aortic size. We need to repeat echo every 4 to 12 weeks. And in certain cases, and if needed, we may proceed to MRI to check the aorta at the whole length. It is very important to start beta blocker therapy for patients with Marfan, though in some cases there is the argument of retardation at the growth of the fetus, so we need to estimate the benefit versus the risk for the fetus. Moreover, we need to have a strict and blood pressure control. We need which drugs are often prescribed for pregnant women, and of course we need to avoid ACE inhibitors, ARBs, or drugs that are contraindicated. Concerning the elective surgery during pregnancy, we know that prophylactic pregnancy elective surgery during pregnancy should be done when the aorta goes over 45 and it increases rapidly. So the exact timing and sequence of delivery and thoracic surgery are not specified, so it is better to go for an individualized approach and plan. If the cardiac surgery is planned with a fetus in situ, the woman needs to be informed, of course, for the risks, whereas when the fetus is viable, then delivery may be planned before the necessary surgery. Concerning patients that experience aortic dissection, we need to follow the guidelines of the aortic disease. And as you already know, when there is a type A dissection, we go for a surgery, whereas a type B dissection with no complications go after a conservative treatment. Concerning delivery, patients with an ascending aorta less than 40 are encouraged to go for a vaginal delivery, whereas patients with an aorta over 45 need to go for a cesarean section. There is the gray zone in between 40 and 45, so I think this is better for an individualized approach. And going to the conclusions, it is very important that Marfan patients have a very good follow-up in specialized centers with an MDT meeting discussing about every change that is seen in the follow-up. Indeed, Marfan patients have an increased risk of complications. However, when these patients have a good follow-up, counseling and risk assessment before pregnancy, it shows that they have a good outcome. And so the most important thing is the pre-pregnancy assessment and the very good follow-up during pregnancy by a specialized team. Thank you so much.
Thank you, Maria. Excellent presentation. And thank you for keeping on time, but we're running a bit behind. So I think we should leave the discussion for the end, Maria. Great.
Thank you so much.